Hey everyone, this is Jason from Intricate Art Spine and Body Solutions. You can check us out at intricateartseminars.com. Today I just wanted to talk to everybody about thoracic outlet syndrome, right? So thoracic outlet syndrome, typically thought of as a problem with the thoracic outlet, which is right near your first rib, right? You get your brachial plexus, which is all the nerves coming out of your neck. You got your vasculature coming out of your neck, and those all go down and go a portion of them go through your thoracic outlet, right? So one of the primary things that happens with thoracic outlet syndrome is the very first rib, right? So the top rib, it gets elevated upwards, it gets popped out of place upwards. And when that happens, it puts abnormal stresses and strains on the neurovasculature coming out of the neck, and it causes a relatively big problem, right? It can cause you upper extremity radicular symptoms, it can give you tingling and numbness, weakness in your arms, it can give you headaches, all sorts of stuff, right? So there's a lot of reasons why thoracic outlet syndrome can happen. There's a lot of reasons why the first rib can get displaced up out of place, but for this conversation, let's just talk about two muscles in particular that I think can really relatively directly affect the first rib and the thoracic outlet, right? So the first muscle that I think about usually is the middle scalene muscle, right? So all of the scalene muscles, all three of the scalenes, the anterior, the middle, and the posterior, they attach to the first rib. As far as dry needling goes, the only scalene that we can definitively target because of palpation and safety is the middle scalene, right? So the middle scalene attaches from the first rib up to the second cervical vertebrae. Here, hang on, let me get my little spine model here. Okay, so here's the neck, right? So the middle scalene is attaching just like my fingers are, right? So the middle scalene attaches on the posterior aspect of the transverse processes, and it attaches just like my finger all the way up to C2, and the bottom attachment is on the first rib. So if my finger there is the first rib, the middle scalene attaches down on the first rib, and then it goes up and attaches on the posterior aspect of the transverse processes of C2 to C7 is what most books say. So one of the primary reasons that the middle scalene is such a problem causer is where it attaches, right? So if the middle scalene gets tight, so if it's sitting here and it gets tight, and that muscle gets tight first, right, that's going to put tension on the first rib, and it's going to pull the first rib up. Or it's going to pull the cervical vertebrae down. It's usually a combination of both. So it's going to compress the cervical spine, and it's going to pull the first rib up, right? If the middle scalene gets aggravated first and your first rib gets elevated, that's going to pull your entire rib cage upwards. If your entire rib cage gets pulled upwards, that's going to stress a lot of other different muscles. But as far as anatomical position goes, the quadratus lumborum, the QLs, are the most similar muscle to the scalenes on the opposite end of the rib cage, right? So the QLs are down here. The QL attaches the 12th rib to the lumbar transverse processes and the iliac crest, right, and the ilium. The middle scalene attaches the first rib to the cervical spine and to C2, which is very important. We'll get to that in a second. So if the middle scalenes get tight first and they pull the whole rib cage up, that's going to pull and stress the QLs because they attach the bottom part of the rib cage to the pelvis. So if the QLs then are getting pulled upwards, stress muscles get pissed, the QLs get tight, and then the QLs start pulling the rib cage downwards. So that is an issue because now we have muscles at opposing ends of the rib cage. So we got the middle scalene up here, and we got the QL down there that are tight, so they're pulling the rib cage in opposite directions. That's going to depress the 12th rib and elevate the first rib, and both of those can cause problems, right? In the pelvis, first rib specifically for thoracic outlet syndrome, it puts pressure on the vasculature. It can cause all sorts of other problems. One of the other reasons that the middle scalene is such a problem causer and is such an important muscle to needle is that the middle scalene, like I said, it attaches directly to C2 spinous process. So C1, C2 is the most mobile joint in the spine. So About 50% of our cervical rotation comes from C1 rotating on C2, right? So if I turn my head to the left, I have pretty mobile neck. I have about 50 degrees, 45 degrees of rotation to either side. Or sorry, I have about 90 degrees of rotation to either side. 45 or 50 degrees of those is coming from C1-2. So because C1-2 is the most mobile joint in the spine, it's the easiest joint for our body to self-compensate for deviation anywhere in the spine. So if we get a deviation in the lumbar spine, it's easiest for our body to self-correct by counter-rotating C1 on C2 because it is the most mobile joint in the spine, right? There's no other joint in the spine that has more than like 10 or 15 degrees of rotation. C1-2 has 45 or 50, so it's a huge difference. Because the middle scalene attaches to C2, if the middle scalene gets aggravated and pulls the first rib up, it's also going to be pulling on C2, and since C1-2 is such a mobile joint, C2 gets easily deviated, and then it becomes a combination of a bunch of problems. So one of the issues that happens at C2 is that the trigeminal cervical nucleus sits in the dorsal horn of the spinal column at C2, right? So the trigeminal cervical nucleus is the bottom section of the trigeminal cervical complex. So the nucleus sits about where my finger is in the spinal cord. The complex comes up through the brainstem and it goes through the like the default mode network of the brain, the old brain, right, where our amygdala is and our hypothalamus, and then it translates afferently up into the cerebral cortex. So the trigeminal cervical complex, when it gets aggravated, severely elevates sympathetics, right? So overall, the vast majority of people are suffering from sympathetic autonomic hyperactivity because just life in general, mental and physical stress, strain, and trauma all elevate sympathetics. The more C2 gets aggravated and the more inflammation in your neck you have, the more the trigeminal cervical nucleus is going to get aggravated, and scientists have shown that disruption of the afferent signals crossing the trigeminal cervical nucleus may be indicated as a causative factor for cervicogenic dizziness, loss of balance, all sorts of stuff, but it definitely elevates sympathetics. So if the middle scalene gets aggravated, it's going to pull the first rib up, it's going to deviate C2, it's going to aggravate the thoracic outlet itself, and it's going to also aggravate and stimulate the trigeminal cervical complex into sympathetic hyperactivity. One of the major points inside the trigeminal cervical complex, in the center of the brain, right, if you guys remember from physiology class, there's a little marble-sized thing in there, smaller than that, called the locus ceruleus, or the LC, right? The locus ceruleus is one of our primary epinephrine makers of our body, right? It's the primary epinephrine producer as far as I understand. Epinephrine is a sympathetic neurotransmitter, right? So the more epinephrine we have in our body, the more our sympathetics go up, the more anxiety we have, the more our cortisol goes up, the more hyperalgesia, allodynia, things like that, pain to a non-painful stimulus, all that stuff elevates when the trigeminal cervical complex gets aggravated, right? So aside from the middle scalene attaching directly to the first rib, it attaches to C2, so it aggravates the thoracic outlet and the trigeminal cervical complex, which those two things in and of themselves can become like a detrimental feedback loop where one gets more aggravated, it aggravates the other one, you get more pain, more neurologic symptoms, more problems, and it just keeps going like that. So the reason that I like to treat the QL and the middle scalene together is because they're on basically the opposite sides of the rib cage, and they can both cause thoracic outlet syndrome. So QL tightness alone, if the QL gets tight first, that's going to pull the rib cage down. It's going to do exactly the opposite of what we just talked about. That's going to aggravate the middle scalene. That's going to make the rib cage depressed, and then when the middle scalene gets aggravated and pulls up in the first rib, a stuck downwards rib cage makes it much easier for the middle scalene to pop that first rib up out of place and cause significant neurovascular problems, right? So as far as needling goes, the middle scalene is the only one that we can palpate, right? It sits right off the backside of the transverse processes, so that's a relatively easy one to needle. The QL is an easy one to needle, right? And then aside from needling for thoracic outlet syndrome and its related impairments, spinal manipulation is very, very important to add into your treatment, and I think that doing manipulations following dry needling is the best way to do it, right? Because dry needling loosens up the muscles, it causes increased blood flow, it makes the manipulations more easy to do, it makes them more comfortable for the patient. It keeps them as a longer lasting treatment, right? Because if you just force your way through super tight muscles, you can get a cavitation, but the joints are just going to get popped out of place, right? So after you needle, it's really important to go through the entire spine and deviate and reduce all deviated joints to neutral, right? So again, because the middle scalene attaches to C2, and because C2 is the most mobile joint in our body, deviation anywhere else in the spine is going to cause secondary deviation of C2 and aggravation of the middle scalene, and then secondary to that, QL aggravation, trigeminal cervical complex aggravation, right? So I like to needle first. Make sure you do multifidus needling. That's very, very important to include before you do spinal manipulation. And then make sure to go in and specifically address all deviated joints in the spine. They're all very, very important because C2 deviates in response to deviation of any other joint in the spine. So I like to manipulate. I typically go from upper cervical down to lumbar, and then I address the extremities after that. So for thoracic outlet syndrome, if you wanted to pick just a couple of specific muscles to target, the middle scalene and the QL are opposing muscles on the rib cage. A tight middle scalene pulls the rib cage up, a tight QL pulls the rib cage down. If they're both tight, the ribs start to get deviated, right? And then after that, you go through and perform your spinal manipulations. This will make the cervical manipulation, the lumbar manipulation, all that stuff much easier if you go in and needle first. Make sure to get the QL, the multifidus, and just another one to think about as far as a big spinal compressor is the psoas major, since that sits kind of opposing to the multifidus, although it doesn't cross as much of the spine, right? If anybody has any questions about anything, or if you would like to take a class of ours, you can check us out again, intricateartseminars.com. We do have an online course right now. It's how to treat the autonomic nervous system specifically with dry needling. It's a 15 CEU course for $299. It's a really good one. Thanks for watching.